This training video is a primer on risk and safety, which involves a review of the key concepts that the Living with Risk decision support approach addresses. In order to understand our place within risk assessment and management, we need to understand our personal and professional thoughts about risk. Think of a few things that you have done recently that either you or someone else would label as being risky. Then ask yourself, why did you take these risks? It is also important to reflect on what your risk journey has been. My risk journey started with being unsatisfied with my ability to be an effective clinician in supporting caregivers around risk. On the one hand, I had caregivers who wanted me to relocate their mother ASAP because of dirt in the home. While I would calmly explain we can't relocate people for concerns of dirt, what if the dirt was mouse poop in the microwave that the client uses to heat up their food? Then I had caregivers who acknowledged that they knew that their mother was living at high risk and that they were willing to support this, but they wondered when it became neglect on their part. Clinicians also wonder if supporting activities that lead to adverse outcomes can be classified as neglect. My reflections on risk also made me realize that I had become desensitized about risk. I was quick to hide behind the cloak of client-centeredness, and I wondered if I over-prioritized autonomy and whether all of these perceptions were putting the older adult at higher risk of adverse outcomes. So what do we know about living with risk? We know that home is where the majority of older adults want to remain even if their health changes, and home is also where the majority of older adults want to be discharged to following hospitalization. However, declining health and/or functional status can sometimes lead to an increased risk of adverse outcomes. In these scenarios, clinicians want to support the older adult's goal of remaining at home at the same time as wanting to prevent any adverse outcomes. This then leads to assessments of risk and safety. So what do we know about the factors involved in the decision-making of remaining at home? This systematic review identified all the factors influencing decision-making about housing options among older adults with a loss of autonomy. Factors were grouped among 6 different dimensions. There were factors related to the person's social environment, built environment, time and space, economics, socioeconomics and health, and psychological and psychosocial factors. From 88 studies, 52 factors were identified, yet only 2 specifically require input from health professionals. This one, physical impairments and health status, and overall health professionals' input. So while we have valuable information to help older adults with their housing option decisions, there are 50 other factors that might also influence this decision. However, health professionals are well positioned to support older adults to remain at home, as it is within our expertise to address the majority of the following barriers to aging in place reported by older adults. They indicated that home mobility and safety, personal health, access to community services, home improvement and maintenance, general home safety, and bathroom safety were all areas that they identify as being barriers to aging in place. With regards to safety at home, what do we hear? We hear inpatient managers say that staff are delaying discharge when they are concerned about the patient's safety. We hear community managers say that acute care is not discharging patients home. We hear hospitalized patients say that staff are spending too much time focusing on the risks and things they can't do rather than on things they can do. And we hear older adults at home say, "I'm only leaving this house, feet first and in a box." So what are the results when safety is a concern? Sometimes patients who want to go home don't get home. Sometimes patients do get home, but caregivers are stressed. In both cases, when patients don't get home or go home, clinicians have more distress about it. And ultimately, there is a system-level impact when patient flow is affected due to safety concerns. So what do we know about clinicians and risk? We know that clinicians define risk natively, they define living at risk negatively. They define living at risk differently. We focus on the negative consequences of risk-taking, the physical consequences of risk-taking, but we assess risk comprehensively. So why is risk assessment and management so hard? It is hard because there are tensions. Clinicians are constantly balancing the bioethic principles of do no harm and do good on the one hand, with the right to autonomy and self-determination on the other. Clinicians are having to balance different types of decision-making. Clinicians place a high value on evidence-based practice and rational and reasoned decision-making, which is hard to balance when others come to the therapeutic relationship making decisions emotionally. Clinicians are balancing tensions between outcomes. Clinicians hope and want the absolute best for our older adult patients, but we are also required to support the minimum standards of living, which is hard to do. Lastly, goals of care differ between clients, caregivers, and clinicians when there are safety concerns. So what are the solutions? Clinicians are better able to support their patients to live with risk when we broaden our definitions of risk and living at risk, when we clarify our definitions of risk and living with risk, and when we broaden our approach to risk assessment to be more balanced and to include shared decision-making. Let's look at these solutions in more detail. As previously indicated, most people define risk as something negative, as outlined in this definition of risk from the dictionary. Risk is a situation involving exposure to danger with the possibility that something unpleasant or unwelcome will happen. Healthcare's focus on risk being negative is highlighted in the following phrase that is used often in healthcare. The risks and benefits of something are this and that. Clinicians are better able to support their clients to live with risk when they adopt a more neutral definition of risk that acknowledges that taking a risk can lead to both positive and negative consequences. Thinking back to the activities you highlighted in the beginning of this webinar, why did you take these actions? Do you go into these actions or activities to achieve the negative consequences or the positive? In general, the majority of the time, we are doing a risky activity to achieve the positive outcomes. And so the more neutral way of saying this last phrase is, what are the harms and benefits of something? The clinicians in the first study of this approach define living at risk as being a judgment about an impairment within an environment that can cause a perilous event that has the increased potential for negative consequences. However, clinicians are better able to support their clients when they broaden their definition of risk from being at risk to living with risk. This understanding comes from the acknowledgement that we are all living with some kind of risk and that risk exists in all parts of living. Providing care that supports living with risk focuses on optimizing health, leveraging strengths, adapting environments, and acknowledging the positive consequences of the action. Clinicians are better able to support older adults to live with risk when they clarify what they are calling risk. Surprisingly, the clinicians in the first study of this approach all define risk differently. Some clinicians referred to risk as an impairment or related to the older adult's personality. Others referred to the older adult's environment as being risky. Others described the concern as being the risk, while others described the consequences as being risky. When talking about risk, clarify what you mean, and more specifically, the approach will ask you to start with the concerns that you have about the older adult. Clinicians are better able to support older adults to live with risk when they broaden and balance their assessment of risk. This means acknowledging the negative consequences of taking the decision, but also of not taking the decision. This means acknowledging both the physical and emotional consequences of a decision. For instance, when we are recommending relocation from an older adult's home to minimize physical harm, have we acknowledged in the discussions the emotional consequences associated with no longer living in one's home? In situations where we delay discharge from hospital due to the safety concerns we have of the older adult returning home, have we also acknowledged in our discussions that the older adult is at increased risk of negative consequences by remaining in hospital? And lastly, in your discussions, have you acknowledged both the negative and positives of risk-taking? What are the benefits of living with risk? What is one overall positive consequences of risk-taking? It's resilience. So by supporting living with risk, we are supporting the building of resilience, as resilience, by definition, can only occur when a risk has been taken. High resilience later in life has been associated with reduced depression and mortality risk, better self-perceptions of aging successfully, and increased quality of life. When we are personally taking risk, we only ever think of the rewards of taking the risks, yet when we put on our clinician's hat, we only consider the negative consequences. So we need to have a shared decision-making process so that we can bring to the table our expertise in illness, disease, resources, and why we have concerns, but so that we also understand from the patient what the reward and positive consequences are, as they are experts in their life, in their goals, their dreams, and what the rewards and positive consequences are.